Good morning, good afternoon, and welcome to the first session of the second day of the Digital Health Society Summit. This will be the discussion hosted by 4PCAN Project and All CAN. The topic is building efficiency in cancer care to improve health outcomes. I wish you a good discussion.
Welcome to this session on building efficiency in cancer care to improve health outcomes. Special thank you to the ECH Alliance and to 4PCAN. My name is Eduardo Pisani. I am the Chief Executive of All CAN International, which is a non-profit, multi-stakeholder global organization active in more than 20 countries and focused on improving efficiency in cancer care. In other words, promoting accessible, patient-centric, evidence-based and quality care to achieve best possible outcomes and experience for all cancer patients at individual and population levels. As you will see on the slide illustrating the work and introducing the work of All CAN International, there are a couple of elements that I would like to submit to your consideration. Number one, we are people-centered, which means to align all aspects of cancer care and prevention to meet the needs of patients, carers, and the general public in collaboration with the people concerned. And the second characteristic is to take a whole system perspective, which implies to treat each patient's care pathway and the entire cancer care system as an integrated whole. Efficiency is perhaps a buzzword which actually connects very well with value-based healthcare, sustainability of healthcare systems, and these are topics that we will discuss in the course of this panel. Actually, as a cross-cutting dimension of health systems performance, efficiency is related to all components of performance, just as are the domains of equity, resilience, and sustainability. Hence, the measurement of efficiency is important at all levels of decision-making in healthcare systems, whether it's systemic, whether it's organizational, and individual. I have the privilege today to moderate this discussion with an all-star panel of experts with different professional backgrounds and different perspectives. However, all of them with a very clear mission that is to improve health outcomes for cancer patients. So I would briefly introduce Professor Christobel Saunders, oncologist at Melbourne Medical School. Good evening, Christobel in Melbourne. Alex Filicevas in Brussels, who is the Executive Director of the World Bladder Cancer Patient Coalition. Good morning, Alex. And good morning, Matt Hickey, who is the CEO of the Health Value Alliance. First, before I turn to Christobel, why are we talking about efficiency in cancer care in the context of the Digital Health Society Summit 2024? Because, at least as an initial thought and do not forget what we have seen in the short video clip at the introduction. In order to achieve our shared goals, we need to harness the potential of data to transform cancer care. Whether we are talking about clinical, genomic, patient-generated, these data have shown the ability to drive quality, innovation, and value in cancer care. Also, we need to drive towards adaptive and learning healthcare systems that enable better and more equitable use of resources now and in the future. Therefore, measuring outcomes and health system performance is paramount. So, in essence, and in closing my introductory thoughts, we want to promote implementation, align organizational frameworks, data systems, policies, and incentives towards efficient care, and digital tools and digital solutions are an integral part of these efforts. Without further ado, I would like now to invite Christobel Saunders, perhaps to tell us her perspective on a recent project that was launched by Allcan International that we call the Action Guide for Efficient Cancer Care, and that speaks to several of the points that I have just started to put on the table. Christobel.
Well, thank you very much, Eduardo, and it's an absolute delight to be here this evening and to give you a really practical, I hope, brief talk and a walk through how we've tried to go about how we can really try to measure this thing that we call efficiency in cancer. And as a surgeon, I always like to have very practical solutions, and I hope that you'll find this interesting. So as Eduardo said, we've recently undertaken a body of work where we've developed what we call the Allcan Toolkit, or an action guide for looking at cancer efficiency metrics. And if we could have the next slide, please, I'll try to explain to you a little bit about what this is. So firstly, let me define what we mean by efficiency at Allcan. And we very much do not think of efficiency in terms of monetary efficiency. How we define it is care that delivers the very best possible outcomes using the human, the financial, the infrastructural, and the technological resources that are available, but very much with a focus on what really matters to patients and also to society and the systems that are delivering care and better health. So we thought to ourselves, how can we go about measuring this efficiency? Because if you can't measure it, it's very hard to improve it. So we initially started some work a few years ago with the University of Southampton, and Matt Hickey, you'll be hearing from shortly, was very involved. And after a lot of review of the literature, after looking in depth at what was out there in terms of measuring cancer efficiency, we came upon 8 metrics which really can be used to try to coalesce together and get some idea of how well you're doing at delivering cancer care, whether you're a unit delivering care in one specific cancer, whether you're a hospital or institution, whether you're a whole service, an area, or indeed whether you're a big jurisdiction such as a country. You can use these metrics to really define how well you're doing, to give yourself a temperature check. So what are these metrics? Well, the first one that's really important is how long does it take to get my cancer diagnosed? And when we asked patients, that was something that's really important to them. Secondly, a metric which is quite clinical is how many cancers are diagnosed through the emergency department. Because the last thing that you want to see is a patient turning up with their large bowel obstruction in emergency when we know they'll do very badly. What we want is for them to go to their general practitioner or their community health practitioner to say they have a symptom and their cancer being diagnosed at a very early stage, or perhaps even better through a screening program. The third metric is around what we call the primary care interval. And that's really defined as how long does it take for your general practitioner or your primary care practitioner from when you first present with a symptom for them to send you off to a specialist for what turns out to be your eventual diagnosis of cancer. And of course, importantly, the time from when you get that diagnosis to when you start treatment, which is a very good measure of how robust the hospital system is at caring for cancer. Other important measures are around the workforce who are looking after you. And we know that cancer nurses are probably one of the most important and pivotal parts of the workforce. So were you seen and looked after by a cancer nurse specialist? Another important measure is around futile care or low value care. And so a good measure of this is how many patients during the last 2 weeks of their life received chemotherapy, which inevitably will be futile care. And then the last two measures are around patient-centric measures, much harder to define, and we'll come on to that in a moment, but around the patient experience of their cancer journey, and how do we measure that, if indeed we do, and around the patient's involvement in decision-making, and if they had enough information to make the appropriate involvement that they want in decision-making. So we moved on to a fantastic project run by the University of Amsterdam, along with ourselves, to really put that together into an efficiency metric study and this toolkit. And perhaps, Eduardo, you could kindly put in the chat for everybody a link to that toolkit so people can actually go there. And what you can see is that really these metrics are in three clusters: around timeliness of care, those are those initial ones, around the coordination of care and who's looking after you, and around patient-centeredness. And when you use these metrics and you use this toolkit, you can see that you can come into the metrics at different points, or you can identify where perhaps you think you may have a problem, measure that, and therefore then go back and remeasure using these metrics to see how well you're doing. So I'll finish with one example, if we could move on to the next slide. And this is not an example of anything to do with me. This is actually from one of our Allcan partners in Argentina. And first they identified a problem. And I'm sure you'll recognize this problem. Their problem really was that patients seemed to bounce around a lot when it came to actually getting the care that they wanted, that they didn't seem to be able to navigate their way through care because there was lots of different and confusing places and a lack of coordination of care. So they thought, what could be a solution? And they thought perhaps a solution could be cancer patient navigators. So they worked out phases of how to introduce those through implementation, talking to lots of stakeholders, identifying what they needed in terms of resources, in terms of buy-in, including political buy-in to get these navigators up and running. And may I say, we're currently doing this in Australia. They also looked at some of the barriers. How would these people get paid? Who were they? Did everybody need a person? Or can it be, in fact, a data solution and an AI solution to this cancer navigation? And then if we go back to the previous slide very briefly, what can then happen is you can go back and look at your metrics and see how did you do before the introduction of cancer navigators, and how have they improved the efficiency of your cancer care? So that gives you an example of perhaps how you can use this. And at that point, I will pass you back to Eduardo. Thank you.
Thank you very much, Cristobal, for setting the scene so clearly. Perhaps before I pass over to Alex, just one thought with regard to the link between efficiency and value-based healthcare, which is, I know, a theme that is very dear to your heart. Just one sentence or 1 minute.
Yeah, so value-based healthcare and person-centered value-based healthcare really revolves around delivering the outcomes that matter to patients over the cost of delivering those outcomes, but also taking into account the individual in front of you's goals, aspirations, and preferences for treatment. And in fact, if you deliver the most efficient cancer care, you are delivering both person-centered care and the very best value care. So really, we're almost talking about the same thing as value-based healthcare, but we're adding in efficiency. And I think the other very important thing that we're doing is thinking about the equity lens. And I might come on and talk about that a bit later if we have the opportunity to, Eduardo, about how you may add or subtract to those metrics, things that are more important to you. Thank you.
Fantastic. Thank you very much indeed, Cristobal. Now, I think it's really timely to ask Alex, from a patient advocacy perspective, what does it really mean for you advancing efficiency and outcomes measurement as well? For instance, even in our action guide, we make reference to patient-reported outcomes measures, patient-reported experience, in order to improve the quality of care and the quality of life. Alex, floor is yours.
Thank you so much, Eduardo. It's a pleasure to be here today. And I do not have any slides, so I'll just be sharing some thoughts and saying thank you so much, Christabel, as well for your initial presentation. I think it's a great starter to our conversation here. I always like to mention, I think we cannot stress it enough, that efficiency in cancer care isn't just about managing costs or optimizing resources. Christabel already touched on this, but I always like to reiterate this because it is about ensuring that every aspect of care delivers real value and meaningful outcomes to patients. So efficiency, when done right, can reduce delays, simplify care pathways, and most importantly, improve the quality of life for patients. And so at the heart of this approach are patient-reported outcome measures, so PROMs, and the patient-reported experience measures, which are acronymed as PREMs. These are two essential tools that capture patient voices, so their health status, their experience with the care that they receive. And so both PROMs and PREMs shift the focus from simply treating cancer to truly caring for the person behind the diagnosis, the real person behind it. So I look at PROMs as a way of measuring what matters most to patients. PROMs allow patients to report on aspects like pain, fatigue, let's say mental health and physical functioning. And these are all elements that directly affect their daily lives and well-being. And for instance, the AllCan patient survey we published from AllCan International a couple of years ago found that nearly 40% of cancer patients reported symptom management as an area of high unmet need. So by capturing this data, healthcare providers can then gain actionable insights that allow them to adjust treatments, for example, based on real-time experiences of patients. A patient undergoing chemotherapy might report severe fatigue through patient-reported outcome measures, and this way prompting their clinician to adjust treatment, for example. This is just a very simple example. And so this doesn't just improve the comfort of the patient, but it can also enhance adherence to the treatment, reduce hospital visits, so reducing the burden on the patient, but also ultimately support better recovery outcomes as well. And one practical example from AllCan Efficiency Hub, which is a repository of wonderful examples from all around the world where efficiency was put into practice in very many different examples, is one I wanted to share here. It was rapid diagnostic pathways for patients with unclear cancer symptoms. So this was acute diagnostic oncology clinic in the UK, which helped improve timeliness by consolidating tests and consultations. So patients with non-specific symptoms, for example, can receive all the necessary tests and consultations in one coordinated visit. And this way, we're reducing delays in diagnosis, so patients can receive a correct diagnosis faster. They can also help faster treatment start and better patient outcomes overall. And then the other part in more detail is the PREMs as a window into patient experience really with their care. And they reflect how patients feel about the care that they receive. So they capture critical aspects like communication, respect, and involvement in decision-making as well. And at the World Bladder Cancer Patient Coalition, last year we published Global Bladder Cancer Patient and Carer Survey report, which showed that nearly 47% of patients felt they were not sufficiently involved in the decisions regarding their care. And so this insight is essential as patients who feel included in decision-making also often report higher satisfaction and better health outcomes as well. And another example, I think, from the UK, in England specifically, where they were leveraging PREMs, so patient-reported experience measures data to guide system-wide improvements across the NHS. By listening to patient feedback, hospitals have made improvements in various areas in patient care. And this commitment also helped to understand and address patient experiences to create a more compassionate and effective care environment. And lastly, I think both PROMs and PREMs not only benefit individual patients, but also enable then healthcare systems to evaluate and enhance care at the systemic level. So from the survey that I've mentioned earlier, we saw that 39% of patients reported delays in the diagnostic phase, and Christabel, you touched on this as well, which then leads to increased anxiety, lack of confidence in the healthcare providers, and it can also have a negative effect and ripple effect on the entire care experience. And so by addressing these feedback points, healthcare providers can then reduce inefficiencies that impact well-being. So I think these are two very transformative tools that shifting our understanding of cancer care from treating disease to truly supporting the person behind the diagnosis. And by focusing on these measures, we can truly build more efficient, responsive, and compassionate cancer care system, one that respects each patient's experience and needs while delivering the best possible outcomes for these patients. And so it is essential, I think, that as a community and also as a society overall, we don't lose focus on patient awareness, also patient education, and support them in their understanding of the condition they are diagnosed with, and aid them in making fully informed decisions about their care as well. Because health literacy is, I think it's a critical element here, and I think we will never evolve as a healthcare system overall if we do not help patients actively participate in their care and listen to their feedback.
Alex, thank you very much indeed. And also in your case, a short follow-on question. You've addressed shared decision-making, the role of collaboration amongst all the stakeholders, which brings me back to the initial considerations about the whole system perspective, the integrated approach. Would you say also a word about literacy and self-care in the case of cancer patients specifically, how this is relevant and is an integral part of the strategic approach that you have outlined?
Yeah, that's a very good point. So I think for patients to be able to actively participate in their care, health literacy is critical. But we see that there is currently, in many cases, is insufficient. And for patients to be able to do that, we need to support them on different fronts. I think that has to come from the healthcare system, so from the healthcare providers. And this is an area where we also need to work together to empower them and educate healthcare professionals and all the providers in the healthcare system on the benefits and how to approach this topic with the patients, and making sure that we provide an environment where patients can meaningfully participate in their care, but also supporting other contributors to this area as well. For instance, patient advocacy groups. We have a lot of patient organizations who provide peer-to-peer support, provide additional information, and helping patients in that shared decision part in understanding different treatment options, what is the condition that they're diagnosed with, and how to make the right decision that makes the most sense to them. And yet in our survey that we published last year for bladder cancer patient experiences, we saw the majority of patients were not even guided or signposted to patient organizations, bladder cancer patient groups, or other patient groups who support patients with bladder cancer, even though these organizations already existed in their countries. So I think collaboration between different stakeholders and different players, this way we can create a really collaborative and supportive environment for patients.
Crystal clear. Thank you very much, Alex. Now, looking at the implementation of efficiency metrics through models, including AI-powered models, which may improve system sustainability, transparency, and lead towards better outcomes and better value, always keeping people at the center of the system. That's perhaps an additional perspective that, Matt, you can offer and complement what Christabel and Alex have described so far. Matt.
Sure. Thank you very much, Eduardo. So I want to build on what Alex, yourself, Eduardo, and Christabel said previously, and look at another practical implementation of the use of the efficiency metrics, an application of the playbook, if you like, So taking the work that's been done through Allcan over the last at least 5 years, because the original piece of work we did was actually asking over almost 4,000 patients what they felt was most important to them. And that was a really great segue into doing a data report, and then into a metrics report, and ultimately into this playbook, this efficiency metrics guide for utilization of practical implementation. And I wanted to start with this context, if you like, from Don Berwick, who's the former administrator of CMS in America. Every system is perfectly designed to get the results it gets. It kind of says one of the key problems that we're facing as an industry or an infrastructure, that if we aren't keeping the patient at the center of everything that we do, Christabel will know this, I know this clinically as well, that the patient is fundamentally our job. And if we don't keep them at the center of everything that we do, then the system itself will inevitably fail, but we will also fail the patient. So I've been in hundreds of policy and strategy meetings and thought leaderships, etc., where we spend a lot of time talking about the infrastructure and not so much time talking about the patient. And what was really interesting with regard to what we established for our, and I think we can move to the next, yes, there we go, I've got the slide going here. When we developed a program called the Cancer Performance Indicator, was bringing stakeholders from across the world, from the UK, US, EU, from over 20 different stakeholders, was to have the patient stand up first at the meeting and say, this is what I need, this is my experience, this is what I need from you, and this is your mandate from me, the customer, me, the patient, if you like. And we developed this thing called the Cancer Performance Indicator, which took the 137 metrics from the first metrics report, the application of the Allcan implementation, got 4 measures, and brought it into a practical approach where we looked at both system benefits. So how does the system ensure that value is created for them as an infrastructure to serve the patient, while at the same time getting the balance with patient-centered value. So what does the system value, and what does, as an infrastructure, and what does the patient value, and how do those two things coalesce to ensure that we're meeting the needs of patients, but as Eduardo said previously, that we're doing so in the most efficient manner with the resources that we have available to us. And Christabel mentioned before, if you're not measuring it, we can't improve it. So it's really important to see this practical implementation of a performance indicator, where we state performance is looking at these performance from multiple dimensions, the different stakeholders that are responsible for meeting patient care across the cancer care ecosystem. Ultimately, what came out of the performance indicator is a model that looks a little bit like this. I'm sorry, it's a little hard to see on your screen. It's a complicated model, as you can imagine. But all of the arrows point to the patient first. So you can see the provider, which is the hospitals, etc. They get the value they require to maintain themselves as a viable infrastructure for service delivery. The payer, be that government or insurance, is a viable, sustainable financial system to pay and reimburse for the systems that have been delivered for the patient. And the innovator, being that pharmaceuticals or medical technology, are also able to innovate and bring those innovations to the market to the benefit of the patient and improve the cycle of innovation for improving patient outcomes. But all 3 of these are working symbiotically, if you like, or as a synergy for the benefit of the patient. And we use a common metrics list, which comes from the Allcan efficiency metrics list, a common data model. All of this data is available in electronic medical records, etc. today, and a multi-dimensional approach to assessing performance. So when you put this into practical implementation, you can start to do some really interesting things. I won't go into all of these different slides, but if you imagine that you're trying to understand a service, one service compared to another service, or a hospital group, if you happen to be a hospital network and you've got provider A, B, C, or D, and how are you performing against the 7 dimensions that we're looking at that are important, that the patients told us were important, that we saw within the reports. Patient timeliness, pathways, the interventions they receive, fundamentally the patient experience, the clinical outcomes and the patient outcomes, their survivorship experience, and ultimately how did the financial system work, but also the finances associated with the patient, financial toxicity, we call that. On the left-hand side, you can see that we've gone into a little bit more detail, in the middle column, a little bit more detail with some sub-measures. So we can do root cause analysis or deeper dive analysis on what is affecting the performance of a particular infrastructure. And on the right-hand side, you can see a complicated set of dashboards where you can start doing correlations and inference assessments and understanding benchmarking and really getting into the detail of where is performance improving or declining and why, and fundamentally how that affects the aspects of patient care with regard to outcomes and patient satisfaction. So I didn't want to go into too much detail, Eduardo, just rather to show you this practical implementation of taking the metrics report, taking the implementation guide, building this into an infrastructure for multiple stakeholders. We now have this live in the US, UK, and in Europe, working across hospitals, across accreditation systems, and also with payers. So just a practical implementation, as Christabel was identifying, that when we choose to do this work and we bring the stakeholders together that can enable this, then great things can happen for the patient. I'll leave it there, Eduardo.
And thank you so much, Matt. I have a little question for you, which sounds perhaps a bit basic to some extent. The measures, the standardization of data sets, etc. It's something that obviously should be agreed and or at least aligned globally. In your opinion, how is the world advancing when it comes to standardization of data sets, etc.? Because obviously what gets measured gets done, but if we are measuring different things in different parts of the world, then it's going to be a bit of a challenge.
I think you've touched on something really interesting. And actually, if I had another slide, I could have brought up another slide where we'd mapped a whole raft of different interventions or innovations that are happening across the world with regard to who's measuring what, whether it's a registry, et cetera, et cetera. And it's a really messy landscape. I think the thing that we found when we brought the collaborators together is that fundamentally we are measuring similar things, whether we're using a registry, whether we're using an accreditation body or whatever the case may be. So what we tend to say to people is don't get hung up so much on multiple measures, multiple different innovations that are out there. Rather that if you choose to measure something, it's better than choosing to measure nothing. As you said, what doesn't get measured doesn't get improved. So the standardization is important, but we don't want to be too standardized either. There's some really interesting findings and understanding what's in the gray areas outside of standardization where we can see improvement. So what we tend to say to hospitals that we're working with, or accreditation bodies or registries, let's have a look at everything you've got. We'll apply the standardization models, and then we'll see what else you could be able to showcase, or what we could learn from that another entity could learn from, and make it a learning environment. So standardization, absolutely important. Using AI helps us with all of that, so that we can bring different systems, etc., together, data systems, etc., together, and does a heavy lifting of the analysis. What is also an important part is standardization of the presentation of the measures, so that we start to get a common way of looking at value and a common way of looking at outcomes for patients. Otherwise, every time we look at a dashboard, it's something different. We've got to learn again, and all just becomes a little bit of a jigsaw puzzle and a little hard.
Many thanks, Matt. I want to also insist, particularly to all those who are listening this conversation, that everything we have addressed to date and so far is very concrete, whether it's the perspective of the clinical oncologist, whether it's a perspective of patient advocates, or whether it's the perspective of experts who look at the systemic modeling of measuring performance. This is extremely tangible, and it is happening as we speak. So Matt, keep in mind that I'll ask you about benchmarking and the AI power behind the model. But now let me move on and move back to Cristobal, particularly to ask for another case study. You illustrated already the example of Argentina, and in particular in Argentina, there is a care navigation model which is being implemented. Is there something that is happening now with regard to one of the metrics or more metrics that we have discussed so far in Australia, for instance?
Well, thank you, Eduardo. There is indeed, and maybe we could put up that last slide of mine with the Australian example. So not this one. If you keep going, please. We'll put up the Australian one that you had up before. Keep going through. Yes, here we are. So when we started to get together these metrics, we thought we'd have a go and see what issues we might have in putting them into practice. So we decided to do this in breast cancer for a number of reasons. Breast cancer, as you're probably aware, is the most common cancer diagnosis worldwide. It's the second most common cause of cancer-related death in women. I work in Melbourne, in somewhere called Parkville, in the centre of Melbourne, at Royal Melbourne Hospital, Royal Women's Hospital, and Peter Mac. So there's three services which are linked together, but they don't function very well together, and we're actually trying to get that together. And actually, when we looked at what we traditionally measure, how well do we do in cancer care? Well, we measure survival, we measure recurrence of our cancer, a few other things, but they don't give us a complete picture of this thing that we call efficiency. So we decided to do a pilot where we would look at all of our patients over a year, and we treat around 650 people newly diagnosed with breast cancer, and see if we could come up with an efficiency score at these hospitals. And as Eduardo pointed out before, we very much came from this lens of value-based healthcare. So we said, what are the measures that we're looking at when we think about value-based healthcare? And they're the time to diagnosis, the time the GP takes to send the patient up, how many patients see a clinical nurse specialist, how many patients have futile care. There are some things we didn't think were important, so we've taken them out of the measure. For example, presentation to emergency departments doesn't really happen very often in breast cancer. We thought really importantly, how can we measure person-centeredness? Do we do that? And that's around the patient experience and their involvement in decision-making, the things that Alex talked about. And then importantly, we have a very multicultural society, as many of you, I'm sure, do live in. Although we have an excellent health system with very good outcomes, we have quite a lot of inequity in our health system, and particularly in terms of our patients from non-English speaking background or Indigenous patients. I have to say it's a blot on the Australian health system that Indigenous Australians, our First Nations people, have 10 years less life expectancy than non-Indigenous Australians, and the gap in cancer is getting wider. So we thought we would try to look at that in our precinct. So we took all the patients diagnosed last year, regardless of their background, not those who were transferred to other hospitals. We are measuring those things which we would normally measure, such as their tumour characteristics, demographics, their treatment details, but also trying to measure the other outcomes. Now, we haven't finalised this yet, so I just thought I'd give you a few tips to where we're finding interesting things and problems. So we want to see how hard, how difficult it is to collect this using traditional patient medical electronic records. We use Epic in our precinct. How difficult it is to collect this data in Epic. Is it possible to do it? So, for example, have patients seen nurses? Well, often that's not recorded in the notes because it may be face-to-face, it may be telephone, it may not be recorded. Do we collect patient experiences? Well, we found no, we don't. We don't have a measure of doing that. So we're having to work out how to do that. Do we have a measure of patient involvement in decision making? Well, we're actually not very good at that either. We don't know how well we do. So we're going to have to work that out. And the equity measure, we haven't got a good equity measure. So we thought we'd use, if a patient comes to the outpatient clinic and doesn't speak English, are they appropriately looked after by a medical interpreter? And so out of that, we're hoping to develop a framework for a benchmark, if you like, of how well what we think is a good service. The Peter Mac Hospital is the only cancer hospital in Australia. It has an excellent reputation, one of the top 10 cancer hospitals in the world. can we benchmark how efficient our care is? And therefore other places around the world could compare with us, at least in breast cancer. And we hope to be able to establish really a global excellence measure for this person-centered, value-based breast cancer care pathways and outcomes. Thanks, Eduardo.
Thank you, Christobel. And again, you mentioned the magic word benchmarking, which I suspect we will touch upon also in another minute or so. Before doing that, however, I wanted to get Alex's view again on the topic of the value of data, of collecting data, and moreover, the value of creating a data ecosystem which helps advancing all the improvements that the healthcare system needs to do. Alex, I know that in Europe there is this important initiative on the European health data space, so perhaps this is something you have touched upon. How important, from your perspective, is the implementation of a health data space in Europe and beyond?
Thank you, Eduardo. So in short answer, I think the data collection is a part where we still have a lot of trust issues to address from patient perspective. There's uncertainty and partially justified fear as well when it comes with sharing that data. So I think there's an educational element to it and some regulatory aspects that still need to be addressed. But as a patient community, we're also working with different stakeholders and with patients to make sure that this happens. And through initiatives like European Health Data Space, we can bring more sort of regulatory frameworks that can build on this trust. And then the other side of it is actually the benefit of data collection and data sharing. As I've mentioned, these are two most important elements of looking at the efficiency, well, from a patient perspective, looking at the efficiency of cancer care, making sure patient-centered delivery, so the collection of patient-reported experience measures and patient-reported outcome measures. And I think that if we can, and I know that we will, incorporate this more systematically, this data collection within the regions, within the countries themselves, and then facilitate that sharing across Europe, I think in this way we can deliver so much more, not just the improvement in care delivery in one country, but truly benefit all patients across Europe and benefit the advancement of research as well.
Thanks a million, Alex. And the reason why I wanted to specifically ask your opinion on the European health data space is actually related to your initial thoughts on the importance of patient-reported data and patient-reported outcomes. So that closes the loop. Thanks for that. Matt, actually, there is also a question from the audience which has got to do with case studies, other examples around the world where the implementation of performance assessments and performance-based systems is actually happening. Perhaps you want to think about that as a potential case study, but in the meantime, if you can expand a little more on the importance of benchmarking, which I think gets really towards the question which has been raised.
Yeah, thank you, Eduardo. And while you were talking, I did find that slide. So it's I think there's 40 different quality accreditation and value-based models between the US, the UK, and the EU and Australia, actually. So things like the Commission of Cancer Accreditation Program for the American College of Surgeons. They oversee the accreditation of over 1,500 cancer programs across America. But you've also got the National Cancer Institute designation for cancer centres, the National Institute for Health and Care Excellence here in the UK. These are examples of systems and infrastructures that have been put in place in some instances with professional societies like the American College of Surgeons. We have the Royal College of Surgeons here in the UK, who are tasked with developing frameworks for ensuring compliance with evidence-based best practice and monitoring these processes. So that, to an extent, will point to perhaps the question in the audience. Going to benchmarking, I mean, that's fundamentally important. What we're lucky to have, I think, here in the UK is one of the largest infrastructures, single population infrastructures in the National Health Service for routine collection of population data of around 90% of the population. The rest is all within the private sector. The two systems don't tend to connect when it comes to data. So when we were implementing our cancer performance indicator to look at performance according to what benchmark, we were able to look at the UK national performance measures, and particularly the patient satisfaction. We were talking about this with Alex a minute ago, the patient satisfaction questionnaire. 37 of the 83 standard measures that we have in the cancer performance indicator are patient experience measures that map directly back to the national patient experience measure of the UK. And what we're seeing in elsewhere in the US and other places is they're looking back to this cancer performance indicator and our benchmarks to say, if we don't have something like this locally, then perhaps we can benchmark against the HVA benchmarks or the benchmarks that you've used with regard to the patient experience measure in the UK. It's really important because if you don't have those benchmarks, you're comparing against yourself. Okay, if you're a network, you can improve your network, but certainly you can develop your own standards internally, but to really expand that and to really grow and to push, the rising tide lifts all boats analogy, where we had this cycle of improvement for patient centricity and outcomes and efficiency, then we need to benchmark internationally. So aligning with a standard or a national benchmark is really important. And I'll leave it there.
Thank you very much indeed, Matt. And there is 1 minute left to this session. It has gone very fast, so I'm sorry that we cannot continue the conversation. However, first, I would like to bring everybody's attention to the action guide, which has been published by Allcan International. You can find it on our website, and there are recommendations on how to optimize cancer efficiency metrics implementation. And of course, last but not least, I would like to thank the panelists, Christobel, Alex, and Matt. And I would like to thank very much again the ECH Alliance and the Digital Health Society Summit for having us today. Enjoy the rest of the program. Thank you all very much indeed.